All right, looking at this frontal chest radiograph of a skeletally mature female, the first thing that grabs my attention is the vascular access port device present on the left side. Now, something unusual here is one of the lines. It's following an odd track, passing inferior to the medial end of the clavicle. It's also noticeable that the tip of the line isn't in its typical position. Despite the film being rotated slightly, we can clearly see that the tip of this line is projected just to the left of the vertebral column over the lower descending aorta. So what does that mean? Well, we can't completely rule out aortic placement on the basis of this radiograph alone. However, that's pretty unlikely in this case. A more plausible explanation would be that it's lying in a left-sided superior vena cava, or possibly a mediastinal collateral vessel. To figure that out with more certainty, we'd want to review any previous imaging and reports. Moving on to the lungs themselves, they are grossly abnormal. There's clear evidence of bronchial wall thickening, and we're seeing a widespread pulmonary infiltrate, most pronounced on the right side and predominantly peripheral in distribution. Interestingly, the lung periphery is relatively spared. The heart isn't enlarged, but the central pulmonary vasculature is notably prominent, which is consistent with chronic lung changes. These findings, they're most likely suggestive of cystic fibrosis. Given that CF often comes with a range of chronic pulmonary complications, it makes sense. It'd be helpful here to pull up previous imaging to track any changes, especially if this patient has recently deteriorated clinically. I'll also note that I don't see any evidence of a pneumothorax. In summary, the diagnosis here is likely a teenager with cystic fibrosis who has a vascular access port placed in a hypertrophied left internal thoracic vein, quite an unusual location, probably due to extensive central venous occlusion from previous venous access devices. Now let's talk a bit about bronchiectasis, which is a feature of this case. In CF patients, hyperinflation is typically the earliest sign, but later on, volume loss becomes more prominent. On radiographs, you'll often see thick-walled, non-tapering bronchi that give off that classic tramline appearance. If you see mucus-filled bronchi, they can appear nodular or even tubular, depending on the angle. A question the FRCR examiners might ask here is about the patterns of bronchiectasis, because it can show up differently depending on the underlying cause. In CF, we're talking about cystic bronchiectasis, which gives that bunch of grapes look on CT. They could also quiz you on identifying any associated pulmonary hypertension, since we know CF patients can develop it in the late stages of disease. In terms of differential diagnoses for bronchiectasis, well, localized disease can be poststructive or postpneumonic, and it's important to mention aspergillosis in these cases. For diffuse disease, other conditions like Cartagener syndrome or immunodeficiencies come into play. Now, before we finish, there's a higher chance that this patient could have situs inversus, which is something to always be on the lookout for when it comes to Cartagener syndrome. And don't forget about the possibility of osteoporosis, something we often see in CF patients due to poor nutrition and chronic steroid use. Finally, let's wrap this up. If you enjoyed this case breakdown, don't forget to hit that subscribe button, leave your comments down below, and share this video with your fellow radiologists. You'll want to stay tuned for more in-depth case discussions like this. Thanks for watching Radiology Made Easy, and I'll catch you in the next one.